in the cervical spine. So we should be getting to approximately 90 degrees here. Again, looking at what's happening through this region, which can be harder to see in rotation than it is in side flexion. Again, we want to see if he tries to compensate with combined side flexion, so where he may try to do that movement as well. So again, looking for that. And again, when he gets to the end of the available range, again, we're going to apply overpressure by placing my hand on his right zygomatic arch, left hand on the scapula to stabilize, and apply that overpressure. Again, if there is any suspicion of instability or vertebral artery problems, this would not be done with overpressure. And again, looking at the right movement as well. And again, we can apply overpressure there. And again, comparing side to side for symptom response. We can then go on and look at the different regions of the spine separately. As I said at the beginning, the upper and lower cervical spines can move independently of each other. So we can look at what happens to the upper cervical spine during flexion extension and the lower cervical spine. These are harder to control and may require a lot of practice to just get your handling right on these, so just bear that in mind. So to look at upper cervical flexion, this really is a retraction of the chin. So I'm going to just again give Dave a little bit of guidance. I want you to bring your chin back and again just a tilt down. And again, really trying not to move through the lower cervical region. Again, looking for any symptom response. You can apply overpressure through the chin, like so. Again, you can give a little bit of guidance through the occiput as well. So that would be upper cervical flexion. We can look at lower cervical extension, or sorry, upper cervical extension by just getting him to, again, stick the chin out and up a little bit. And this can be quite hard not to bring in that lower cervical movement as well. So again, we could apply overpressure down. Again, if somebody comes in complaining of headaches, which may be coming from the upper cervical spine, this can be provocative for them at times. Any of the active movements, it's a good practice to try to do the active movement first, its movement down and its return, and then repeat the movement a second time, applying the overpressure. Also, when assessing rotation, I demonstrated applying the pressure to the zygomatic arch. It is also a good idea to stand in front of the patient so that you can observe their eyes for any nystagmus that might be present. This may again indicate vertebral artery insufficiency or cervical vascular insufficiency. So we can then move on to look at the quadrants. And again, like the other parts of the spine, there is a general quadrant, which is a combination of extension, side flexion, and rotation. And there are many different ways that people do this and many different descriptions of this, but the way I tend to do it is to ask the patient to look up into the corner behind them. So I want you to look over your right shoulder into that corner so that that's bringing them into that extension, side flexion and rotation. Making sure he's at the end of his range, then I'm going to apply overpressure. And again, in this position, I can also observe his eyes for any nystagmus. Again, because this is effectively bringing them into a position that may compromise the cervical vascular structures. So again, it may produce positive symptoms for insufficiency of the vascular system. Again, be cautious with that if you suspect there is any insufficiency there. And again, you would repeat that to the other side. So again, I'm going to get you to look up and look over into this corner over here. And again, applying that pressure. And again, it is easier to stand and facing with the patient facing you to observe that nystagmus. We can also look at the upper cervical quadrant, which would be upper cervical spine, extension, side flexion, and rotation. And again, this is another difficult one to try to localize. So again, we extend through the upper cervical spine. Again, keeping a hand on the head, side flex, upper cervical spine only, and again, rotate. And again, this can be difficult to control, does require practice. And again, it can be provocative for the patient. Sometimes because you're compressing and loading up those upper cervical joints, just beware that you may reproduce either dizziness or you may reproduce even a feeling of headache in a patient who may not normally complain of those symptoms. So again, it is important to use clinical reasoning to decide whether or not that is relevant to your subjective examination and the patient's presenting complaints. We can also modify our movement assessment by doing repeated movements. So for example, we could repeat the movements, the provocative movements that are indicated from the subjective examination or from the objective examination to indicate what happens, the movements as they are repeated over time. So for example, we could do repeated flexion. So again, I want you just to bring the chin down to chest and back up again. And again, questioning him on symptom response, again going back down and back up just to the neutral position, just to straight ahead. And again, repeating back down again, and so on. And we can look for changes in symptoms, whether symptoms worsen or ease, or whether patterns of movement change during repeated movements. We can also use combined movements, and the quadrant is one example of a combined movement, which I demonstrated earlier. And if we were doing a quadrant on the left side, this will be effectively closing structures on the left side whilst opening on the right side. So if we were to use other combined movements, for example, flexion and rotation, again, I'm going to bring Dave down into flexion, just guiding him down, and again, adding in that rotation. And again, I'm guiding him through that movement. He's actively moving. I'm just trying to maintain the position. So in this position, we are now effectively producing a opening on this side as he flexes and rotates. He's opening on this side. However, on this side, although he's flexing, he's also closing. So this would be a kind of a regular opening pattern, but this would be an irregular pattern because he's rotating and flexing on that side. To add compression to the cervical spine, I'm going to ask you just again, you can put your arms down by your side. To apply compression, I would just put my hands on the top of the head and press down. So I'm not actually adding in movement, I'm just compressing vertically through the spine, and I can do distraction by lifting up. So again, applying effectively a pressure up through the spine. And that would be for testing the cervical structures. Again, really assessing for symptom response there, particularly if somebody had arm pain. This might be quite useful to see if the arm pain changes with compression or distraction as you are loading any nerve roots that might be implicated. We can then move on to look at thoracic movement. And again, within the thoracic spine, we can again consider the thoracic spine as two separate regions where we have the upper thoracic spine, which can behave quite like the cervical spine and is quite linked to the cervical spine when we look at various parts of the assessment. And then we have the mid and lower thoracic spines. As we go into further down into T11, T12, that's often considered as part of the lumbar spine assessment. If we look at thoracic spine generally, we're just going to get Dave to put his arms across his chest like so. Okay, and now we're going to just ask him to flex forward. So what I want you to do now is just to bend in the middle, like you're slumping in the middle. Okay, now be aware that in this position he's also flexing his cervical spine. So again, that might be important to note. So again, this time I want you to try and keep that chin tucked in. And again, just try and bend from here. So again, you might want to differentiate. So that is, he is not flexing as much through the cervical spine. That might produce conflicting results or confusing results if he's flexing both regions. Again, we can apply overpressure. So bring him back up, assess his pain and symptoms through range, and then repeat the movement, applying overpressure. So again, guiding him down, and then we can apply overpressure like so. Okay, again, be careful not to put any pressure through the cervical spine. My pressure is going through my two hands here. We can also assess extension. And again, we can just generally look at extension. So this time the instruction to the patient would be to lift the sternum up to the ceiling, up here. So again, extending back. And again, noting whether or not he's also going to get a little bit of cervical extension as well. And we can see there's very little extension through this thoracic spine. Again, we can apply overpressure. So again, I'm going to apply overpressure through the hands here, extending, and I'm going to stabilize here so that I can apply overpressure. And I can vary my pressures, so I can apply overpressure through here,